Welcome, everyone. I see a lot of people coming in. Some names that are recognizable. Others are new. I hear that we have people coming in from all different countries across the world. So, bienvenidos, bienvenue, willkommen, welcome. And my name is Arnie Snapvangers. I'm co-founder of Eagletie. It is my pleasure to welcome you here and to introduce this webinar. We're very excited to partner together with Appenzeller today, and we have a fantastic presentations for you. And so, if you have any questions, then I encourage you to use the chat and ask your questions there. And in principle, we will answer the questions at the end of the webinar, but we'll go with the flow and see how what works best. Yeah. So let's get started. So this webinar we're going to get personal, and with very good reasons, and we're going to give you lots of examples why we all should go personal in the near future when it concerns specialty contact lenses. Each eye is unique, and the essence of getting personal is all to do with exactly that. So we're here with Appenzeller and with Eagletie, but also with our expert in clinic here, Cian Gildea, a long-time user of the eye surface profiler, a super educator, and you can of course see his curiosity, his hunger to learn with all the fellowships that he has gathered across along the time. Based in Ireland, and where in Dublin he got his bachelor's of optometry, and then spent 6 months at the University of Houston College of Optometry to further hone his skills, and has a ton of experience with highly irregular eyes, highly pathologic eyes, and has a fantastic passion for finding the best solutions, the best scleral lenses for his patients. So we are absolutely thrilled to have him as a guest speaker, as a keynote speaker here this evening. And also here is Bernd Brückner, and he has a Master of Science in Vision Science and is co-founder of Appenzeller. And Appenzeller is a lens manufacturer based in Switzerland, and they have recently come out with the iShape, a freeform scleral lens, and this is how we will get personal this evening. So we're very excited for his contribution this evening as well. He is not only working for Appenzeller, but also seeing a lot of patients. So he's hands-on with, putting into practice what they're trying to bring to the market. So really happy to have him here. Okay, here we go. Eagletie. So who are we? So we've been around since 2012, a little bit more than 10 years now. We have about 330, it's a little bit more devices out there. And you can see that on the map. Hopefully, there's a lot of dots in the US, and then there's dots in Europe. But you see some clusters in the UK, in Spain, in Italy, and then some spread out over the world. And to our best estimate, more than 25,000 lenses have been fitted through our technology, and we keep on growing. We keep on trying to connect with more lens manufacturers, with more practitioners in more countries, and helping more people to be more efficient. The core technology is called profilometry, and the way that it works is that you instill fluorescein onto the tear film. And if you look at the central image there, you can see a vertical line pattern going all across the front surface of the eye. So the full cornea is always measured, and then anything that is exposed of the sclera as well. And you see there's no holes in the data, and it's equally dense in the periphery as it is in the center of the cornea. And all of that is then transformed into about 500,000 data points. and in a single shot fast measurement process. So those are the kind of the key elements of this technology. So a fast process, full front surface of the eye measured, and capable of measuring also highly irregular eyes. And we'll see some nice examples of that this evening. So make it personal. So what does that then mean? What does it allow you when you have technology and you have capability of going more personal? Of course, you can apply that on corneal lenses with RGPs for pathologic eyes, or with ortho-K lenses, where you take it to a next level of eyes that you're capable of fitting the lens to. All of these things are very important. You want to do the regular cases, of course, but you would want to go into situations where you have more advanced eyes, and you can get to a more personal fit and work with lens designs such as those from Appenzeller that allow you to get very personal on the lens fit. But of course, if you talk about irregularity, the sclera is so much more irregular than we ever had imagined, and it is thanks partly to our technology, this eye surface profiler, that we know so much more about the scleral shape. And if you then on top of that have to deal with a pathologic cornea, a keratoconus, keratoplasty, some other kind of complication on the and then the whole mix of it becomes something where you have to go for a freeform, customized scleral solution, and that of course is the focus of our presentations tonight. Just a few examples shown here. Coming back to the technology, you see 4 steps there. Most traditional devices, they take care of steps 1 and 2. So you have some kind of scanning tool or some kind of photographic tool, and then a software where you can analyze whatever you have captured. And of course, with the eye surface profiler, you can do step 1 and 2. But we really wanted a solution that was a one-stop shop for your specialty contact lens fitting. So we implemented steps 3 and 4 as well. So 3 is about lens fitting algorithms. It's for example in the case of the eye shape and from Appenzeller, is that you can push all of that very precise data that you've measured of the front surface of the eye to the Appenzeller team, and then with their software solution, they can then design this freeform lens. And so 4 is that way how you can actually place that order and push the lens data out to the lab that you choose. And when you push the data out, the other side, so Bernd will have our software and will be able to open the measurement of that particular eye that you want to have that lens fitted on, and will be able to see exactly the same richness of data that you as a practitioner have been able to look at. And so should there be the need for a discussion about some modifications, both sides, so you and your lab partner, have access to the full 3D data of the front surface of the eye. Then we get to the so what. So this is nice, but then so what? Of course, the biggest thing you'll be saving is chair time. So reducing the repeat fits. The previous time with the fit set, there was a lot of trial and error, and of course in steps you would get there. But if you have the 3D data measured, you can reduce those steps significantly. We hear from a lot of our more experienced users that in 80% of the time, the first lens that they fit is the final lens. So chair time is your biggest gain. But it's also, of course, with that, you will be able to get more referrals from optometry practices and optician practices in the area, and also from ophthalmology practices who are not capable or not willing to fit complex eyes with scleral lenses. And for the patient's perspective, having a customized lens on a complex eye gives better comfort. Quite often it can reduce midday fogging, all kinds of other complications that might occur with scleral lens fittings. And it could really have a positive impact on the visual acuity, so on the correction that you are able to achieve. And last but not least in this is that in the empirical fitting days with the trial set, you know, you could talk to various people in even in the single practice, but they each would have their own way that they worked out throughout the years that they built up their experience. And now with this new technology, there is a more uniformity. We have a best practice method that can help you along and make that whole fitting process more controlled and shorter. So then you can focus more on the patient management side of matters, or seeing more patients in your practice, for example. So all of these things are very important. Well, we have about 330 customers out there, and we are, you know, the customers is why we do this, and we are so thrilled that many of them are very willing to step up and share what they appreciate about how our technology enables lens manufacturers to come out with highly customized lenses and allowing them to fit them in a controlled method that helps them to fit it well and with confidence. And with that, it is my absolute pleasure to hand over to Cian.
Thanks, Arnie, and thanks, Bernd, as well, for inviting me to speak about my experience with the I-Shape lens. So it's I think it's 10 years now since I've had the eye surface profiler. So I think it was 2014 or 2015 when I actually got it first. I work in a private ophthalmology-led practice where we deal with a lot of keratoconus, obviously, and refractive surgery. But I also run the contact lens service in a public hospital, the Eye and Ear Hospital in Dublin, and so I don't have an eye surface profiler in the public hospital, unfortunately. So I do fit all my scleral lenses there from a fitting set. And it's quite, what will I say? It's quite limiting in what you can do, and particularly you'll see some eyes that really could do with high levels of customization, but unfortunately, I don't have that access in the public hospital. But it makes a huge difference in terms of fit time. You can fit the lenses, but you're seeing patients back an awful lot to get that final fit. So yeah, so again, my main frustration was chair time. You're even still on more complex eyes, and I've had 10 years experience fitting scleral lenses or irregular corneas at this stage, and even still those complex eyes, you're going to spend a lot of time, and you know, time is inconvenient for you if you're running a private practice. Then if it's in a public setting, you know, it's inconvenient for the patient because they're coming back multiple times and, you know, clogging up the system. So any new technology is a welcome, is very welcome to improve your workflow as well as the patient experience. So I won't spend too long on this, but these are just a few studies that you can look up maybe in your own time as like, why should I invest maybe in an eye surface profiler? So if we look at scleral shape, its correlation with corneal astigmatism, it would suggest that astigmatism is not restricted to the cornea, but should rather be considered a property of the entire eye. Differences, corneo-scleral profile between healthy and keratoconic eyes. So those with keratoconus would show higher levels of asymmetry, scleral asymmetry, compared to those with normal eyes and normal corneas, no ectatic disease. The scleral shape study group Again, this was looking at the correlation between normalized and those with ectasia. So a higher difference, again, if the more advanced the keratoconus, the higher the degree of asymmetry. And here are just a couple of examples just to highlight that last point. So you can see here's an example of an ESP scan. Obviously you can see the cone there, but a relatively small amount of asymmetry. So you're looking at maybe 130 microns at a 15 millimeter cord. If you go out to an eye here with a little bit more advanced keratoconus, so again, you can get an appreciation for how much more advanced that cone is. And then again, look straight away at the, if you look straight away here at the scleral shape, you can see the amount of toricity there, a high level amount of with the rule scleral toricity. So again, 17 millimeter cord, you can see 540 microns of toricity. So again, if you were going to fit that with what will I say, a preformed lens, it could take you quite a while before you get to your endpoint. Now, when you have a scan, when you know what to expect with the lens that you're putting on, or even better, you're sending, you're designing a freeform lens, you'll get to your endpoint much quicker. So personalized medicine, I think personally there's a huge shift in patients looking for personalized medicine. I don't know if you've heard of Gary Brecka. He's on I think he's done some TED Talks and things like that. But he's a guy over in the States, and they do all this genetic testing, and they'll show you what you're deficient in and what supplements you should take, etc., etc. So there's a huge buzz around personalized medicine. But also in I think also in optometry and ophthalmology as well, there's a huge shift towards personalized medicine, and patients are really well informed now. And I think keratoconic patients can be very particular. And there's a lot of keratoconus groups, they'd be talking to each other, who has the latest technology, who fits in my area, etc. They're willing to travel as well to get the best care. So here's an example of somebody of an email that I would have gotten. They're asking specifically about the technology. Can I get a freeform lens? I want high levels of customization, etc. One of the big things that we're looking at down the pipeline as well is the correction of higher order aberrations with scleral lenses. And in order to do that, you need a rotationally stable lens. The way you're going to get a rotationally stable lens is a freeform lens. So I think already having a rapport with somebody who's fitting or somebody who can provide you with freeform lenses, the technology to provide those lenses will set you apart then when it comes to adding higher order optics. So what are the advantages? Objective data better reflects the requirements. The patient feels that their needs are being considered. The practitioner has a greater interest in the outcome. The patient feels that they're being heard, that they're playing a part in the lens selection. This makes a huge difference when you show a patient an ESP scan and you go through it with them. They're sitting at the edge of the chair. They're very engaged, very interested, and very involved in their own solution. The 3D model of the on the ESP, the little tab that you can go into, is a really an amazing educational tool. And all the patients, when they see that, they go, wow, that's my eye. And again, down here, objective data being more accurate than subjective data. So for our advantages as the clinician, better workflow, patient satisfaction, reduced chair time, quicker decision, etc., etc. So Arnie has already touched on those. So this is kind of my thinking about the eye surface profiler. So somebody comes into you with some problems, and you know, what are the patient's needs? What do they want? You do an eye health examination, that's fine. It generates a lot of static, I'd say static data. You know, several $1 million, $100 million per year into eye care, generate objective data that, you know, an OCT might be able to show you an issue, but you know, how are you going to personalize that to the patient? Whereas usable objective data can make a huge difference. So it's something like the ESP. So you're getting objective data from the patient and you're physically creating something that's going to match their eye and that they're going to use on a daily basis and really customized. So it's just a mismatch in those two. So being able to use that objective data in a meaningful way, personalized way, I think is the future of eye care. So I just kind of I looked at progressive varifocal lenses just as an example. So 10% of patients coming back to seek improvement, longer adaptation times. So again, I was just thinking of, you know, a generic lens design, you know, the focus on eye health, not comprehensive solutions. So 55% of customers not fully satisfied with their optical solution. Something that's quite interesting is allowing patients to talk and to describe their problems. So uninterrupted patients only took 6 seconds to describe their vision concerns, and clinicians interrupted the patient after a median of only 11 seconds. So the next time you see someone in your chair, maybe keep your mouth shut for a little bit more than 11 seconds and see what they come up with. So, and that final one, informed consent, I suppose that's another kettle of fish altogether. So I want to talk to you about how to take a good scan. Anybody can take a scan, but it's about getting a good scan. And I spend an awful lot of time making sure that I have good data, because at the end of the day, this is the data that's going to be pushed on to Bernd, who's going to design a lens. He's very good at designing lenses, but that all depends on what you're sending to him. Okay, so how to recognize a bad scan, and just I suppose you can answer this yourselves. How many Purkinje images in the eye? So back to your physical optics there, 101. So here are some examples, and I'll just talk you a little bit through my workflow when I use the ESP, and what I would look out for. So I usually take scans myself. You can do it yourself. I'll show you a little video on that. But also it's a good idea, if you need to have the help of a technician, getting lids out of the way. So if we look at this scan here, that to me, that looks like a pretty good scan on the face of things. But let's start digging a little bit deeper. So there we go. Okay, so we look at the source map. We can see here that the blue dots aren't aligned. Okay, and the reason that that's not aligned is because it's being tricked. The machine has picked up this image here as one of the fixation spots. And that's causing the data not to be aligned. Okay, so that's the first thing that I'll do, is I'll check the source map and make sure that everything is aligned. So that could be down to a reflection from the tears. It can be a reflection from another light source that you have in the room. So you just have to make sure, be aware of your surroundings, check the source map and make sure that the data looks good. Next, here's just another image of what can happen. So it's picked up a reflection here somewhere and it's thrown off the data. So that's the first thing I'll do. The other thing is looking at the grid. You want to make sure that the data is nice and smooth, that there's no dry patches, anything like that. So you're getting good data, and that the tear film is in good condition. So next, that's just another example. I'll use a cotton bud to get the top lid out of the way, and then I'll have the patient use their fingers to get the bottom lid out of the way. But again, you can see that the focus dots are aligned, but then in the middle, you can see that the reflection has thrown the scan off. So next is the bisphere elevation. What we want to look for in this map. So if the source is good, if the grid is good, the next thing we're going to look for is we're going to look for coverage. Okay. So the area I find that tends to get cut off the most is inferior nasal. Okay. So getting the patient to pull down the lid with one finger can work well. Sometimes I'll get them to use two fingers to pull the lid down. And again, if I'm still not getting some good data there, and I'll get somebody in to help me to take the bottom lid out of the way. So we want to look here and we want to see how much coverage that we're getting on the eye. Next, I'll look at the tangent angles. This is a very, very good map. It's great to see if you've got good data. So what you're looking for is you're looking for a smooth map. Any of the lines like what you see here in this scan here, that's all extrapolated data. So you know that the scan isn't good quality. Here's another example of it. You can see all in this area here. So this is the left eye, so that's superior temporal. You can see that extrapolated data. So I would go and retake a scan, or choose another scan that you've taken. I would usually take on average about 9 scans that I'd be happy with, and then I go through and see which one is my favorite. So looking at this, looks like a good scan, good centration, coverage 9.7, which is great. And then we look at the bisphere elevation map. Okay, looks regular. We have this area over to the right-hand side. You saw that little depression there. We'll go back and look at it again. Okay, so good data out to 17, and you can see this little blue area here. Okay, so that's temporal, which does make sense. We know that the sclera, the temporal side of the sclera tends to be the steepest, or the furthest away from the plane. So, but what had actually happened, and this took me a while to figure out, the way I had set up my room, I had my monitor here, and it was going across the patient, and I was actually casting an artificial shadow. So that's what I'm saying. It's just important that you're aware of your surroundings, you're aware of your setup, in order to get the best data and best scan, to provide the best lens, and obviously save yourself time. If you're sending over good data first, you're less chances of needing a remake. So this is a video here that will come up next. So I'm not sure if it's available to everybody, but I'll always instill proximedicane, and that is to reduce blinking. So reflex blinking from the patient, so you get a better scan. I'll always put in artificial tears, a combination of hyaluronic acid and trehalose. So I'll put drops into the eye, then I'll put drops on the floret itself, and then apply a liberal amount of fluorescein onto the eye, making sure that the patient looks up, down, get them to look in towards their nose, out as well, and applying the floret, pushing it, placing it down so that it rests on the globe, and then taking it away. And then I would usually take 3 scans, and then I'll reapply. Okay, and here is a video. I'll spend time instructing them. I'll get them lined up first. I'll give them their target that they're going to look at. And then what I'll do is I'll get the lids out of the way. Okay, so I'll get them to look down first. I'll use a cotton bud to get the top lid out of the way. I'll get them to look straight ahead again, and then I'll get them to pull down their lid, and then I'll take the scan. Depending on the person, if they have quite wide apertures, you'll probably do it yourself, no problem. If they have smaller apertures, you might need some help. But the trick of using, again, inferior nasal tends to be the area that can be tricky to get data. So again, getting them to concentrate and holding it in there makes a good difference. So final check before interpretation. Very important that we look at the HVID and the VVID and make sure that that's capturing it correctly. Again, that's very important. Limbal size and shape has a huge influence on total diameter of lenses. You want to make sure that there's enough clearance around the limbus. You don't want to have unequal clearances. If there's a difference between the HVID and VVID, that can lead to fitting issues, conjunctival prolapse, things like that. So again, very important to make sure that that's all well aligned. And so yeah, you get good data. You look through it. Make sure that you're happy with everything. Tangent angles look good, and yeah, then you send it to Bernd and you get him to design a great lens. So I think over to you, Bernd, for the first
Yes, I think it's now my part. Thank you, Cian, for sharing your knowledge, and also thank you to Elena and Arnie for the organization of this webinar. So let me shortly introduce just our company, and don't worry, I will say something about every picture you see in that slide. Just briefly, our company Appenzeller was founded in 2010. At the beginning, we were 4 persons, and now we are around 40 persons in this company, in this lab. And over the years, we introduce a lot of state-of-the-art products, contact lens designs to the market. We start first with one DEC machine. So we are using DEC machines in our lab. And now we have 6 DEC lathes available, 2 of them with automatic loading system. And that makes us very fast in the production time, and so that you can receive the lens on time, and yes, patient is hopefully satisfied about that. Our latest product introduction to the market was the I-Shape in 2023. So it's now around 2 years old. And let me explain that in the further slides to you. So our contact lenses are available across Europe and also in North Africa, and also in the United Arab Emirates. And yeah, hopefully it will be more countries in future. And yes, but I think it's a good availability of our products across Europe. So before we dive into the world of the I-Shape Freeform scleral lens, just dive into this beautiful view. I take this picture yesterday and send it over to Elena and ask her, please, can you add it to the presentation? So this is a picture of the view out of my office. So it's really wonderful. And I picked this picture up in this presentation for all of you who don't know us as well, who never visit Switzerland or our company. So take a deep breath and enjoy this beautiful view only for a second, and let us switch us over to the first case. So the patient is 50 years old. He's a male. He was referred to me because of an individual fit of scleral lenses for the freeform lens of the I-Shape. And I think, he's 50, and at the age of 20, so 30 years ago, he had a LASIK refractive operation surgery. And after he developed a post-LASIK ectasia, and yeah, he was used to contact lenses before, soft and rigid, and also after the post-LASIK ectasia, he tried to restore the vision with rigid lenses, but wasn't very comfortable to him. But okay, it's many years ago, and but it went better and worse and worse. And so he ends up in keratoplasty on both eyes, and he's wearing scleral lenses, non-freeform lenses, since 9 years, and is reporting midday fogging, increasing intolerance, and also some redness and irritations of his eyes. I show you just the left eye. So here you can see the left eye in this picture. And now I switch over to the eye surface profiler. For that, I share my screen, and I load up the first case. So this is the measurement of that guy. The measurement went very well. So I think I was taking two measurements. He had a big lid aperture, so it was not so difficult to take the scan. And also he was able to pulling down the lower lid by himself very good. So I just have to pick up the upper eyelid and get this image. And yeah, I don't go too much into detail because Cian was already telling how to analyze a good scan from a bad scan. Now I'm just export the data. So what we need from you is the MSR file that makes me gives me the ability to check the data, to see what is the coverage, what maximum diameter is possible for that specific patient. And when I go over and export the CSV file with the X, Y, Z coordinates, I just put it here on my desktop, and it just takes a few seconds, as you can see. And when I switch over to our software and load up these data, and this is our design software. We are also working on a browser-based software, so that you are able to do that also by yourself in the future, hopefully not so long. And when I click on calculate, and what I first see is the sections of the eye in the lower part of this program, and in the upper part of this program, you can see the 3D model of the entire eye, and you can turn it and see if the data are good. So I always look to the last red line to see, is it equal, is it smooth, or do we have some zigzag musters or something like that? It gives me also a good understanding of the shape of the eye. And here you see a scale, so we can move the scale, and what we are doing is 72 angles. And 72 angles means, I can turn this for you, when you look like on a cake, and I give it also enables the front or maybe also the back designs. You can see it now. And you can see these sections. So these are 72 sections, or no, 36 sections and 72 radials. So we have a gap in between each radial of 5 degrees, and we can turn it to see what is the shape, how is it going on. And yes, when I see that, so let me just click that away here, so it's more user-friendly. You can also see it as a heat map to see what is the topography. Can click on here and make it more sharp, I would say. So just to see what it is, but I know is in this case what it is. And now we want to see the lens on the eye. We can make a fully visualization of that. So but let me just explain that to you. You see the black line. This is the current line, 150 degree, and all the gray stuff around this black line is the amplitude. So all the 72 radials putting together in one picture. So of course I can just show the current radial or section and move it to see what it is. And now we put on the lens. Looks like that. You can give in here the power. So the power of that lens and that for that patient is really 22 diopters around that. Also, we taking over the HVID or the horizontal wide to right from the ESP coming. And now you can see the lens in detail. You see that slight curve here. We can change that by switching from prolate to an oblate design, because that is a keratoplasty, and it often fits better with an oblate design. So now we have some extra clearance here in that region. And what I was doing for that guy was a 16.5 millimeter lens. So it looks like that. And now I can see it in every section. We have in the upper part of that program, we see that the section is moving to see where we are. And you can see the shape of the lens and how it matches with the part of the sclera where the lens is resting on. Also, we can show all the details like the front optic zone diameter, the back optic zone diameter, of course, the horizontal wide to wide and the limbic clearance zone diameter. And because by the high power, the high minus power, the lens becomes really thick here in that region. And for that, I would decrease the front optic zone diameter. And you can see in real time how the geometry is changing. And that's the way we work and how we design the lens to achieve the best result. And once I'm satisfied with the fit, with the shape of the lens, I just click on write point files and I can send over the data to the lathe, and the lathe is cutting the scleral lens. And yeah, so now I switch back to the presentation. Here you can see a comparison between the profile on the left-hand side coming from the ESP, and on the right-hand side coming from an OCT. You see there's a really good comparable, so it's the same shape, of course. And with that, I want to tell you that the data are really reliable coming from the ESP, and the first fit success rate is incredible high, and also the conditions that you can measure with that device is also incredible high. So we see the result of the lens. So it was the first lens we made for this patient, and the first lens was also the final lens. And you can see how it clears the cornea, the entire cornea, and also the limbal area, and how it goes over into the scleral landing zone in different sections. And the patient with that lens is really highly satisfied. Yeah. Okay, this is the fluorescein picture I've taken of this patient, and also the white light picture to see better the scleral alignment. So lens is well centered, and I think in the past without freeform lenses, I would fit much more lenses than one, and yeah, that's the thing. Like it is always when I fit now with the technology scleral lenses. As Arnie already mentioned, in 80% it's the final lens. You can see it here more from the side to see the profile of the lens. Because of the high minus power, it looks like a plano front surface, and it matches really well the shape of the eye. So it's perfectly tailored, I would say. And yes, he is highly satisfied. He can wear the lens all day, the whole day. He reports a very good comfort with that lens, no midday fogging. So that's really nice. And yeah, we achieve a visual acuity of 0.7 with him. But on that eye, he wants to have a monovision to read something in the near. And of course, this reduce the distance visual acuity. But he's satisfied with that. And yeah, so that was the first case. And I think now, Cian, it's
That's
your
me.
once again.
Yeah. That was a seriously impressive case. Just the geometry of that lens is unbelievable. And I think you'll see that a lot in older grafts that are like 30 years old. A lot of the time they might not have necessarily got the right the size of the donor was probably too big. So you end up with these huge tilted grafts, these really oblate profiles. So for those types of patients, like it makes a huge difference being able to use a freeform lens. But that was very good, Bernd. So my case here is 41-year-old female. Her right eye is amblyopic, and she developed a lipid keratopathy in the left eye. She's seeing 612 in the right eye, so that's 0.5. And in the left eye, she was seeing 624, so 0.25. She was actually from South Africa, and she found her way to our clinic. It's not moving on for me. Okay. So that's her right eye. So, you know, normal right eye, obviously amblyopic. And then this is her left pentacam. So you can see a high level of astigmatism, a lot of corneal thinning inferiorly because of the lipid keratopathy. And that's her topography. So again, you can see all that noise there. The reason why her visual acuity was quite poor. So we spent some good time getting a scan as good as possible. So we have here good coverage, good centration. Again, went through our checks to make sure that everything was good. So nice smooth data here in the grid. Then we looked at the biosphere elevation. We were happy with everything there. Good amount of data out to 16.5 mil. Go in and we check then, make sure that the HVID and the VVID are set up and that they look nicely aligned. Not a huge difference in the HVID and VVID, so about what is it, 0.18 mil of a difference. So you know, not concerned about that. Look at our tangent angles, and once we're happy with everything, we go into our direct connect. Before I was exporting the files and sending them to Bernd, but now he's got direct connect. I don't need to bother him as much. So sent it on, and so number one, obviously you're showing this to the patient, makes it very interesting for them. But then Bernd also sends you this back. So you can, this is what I would do is at the dispense visit, before I put the lens on the eye, I'll take it out, I'll show it to them, etc. And then I'll show them this. I'll say, this is 100% customized for your eye. This is, and go through the scans with them. And it's a great educational tool, but also the patient gets really, really involved with the process, and they feel empowered as well. So again, here are the scans of the lens that Bernd had sent on. So 785 base curve, a low power, which is great, 16 mil diameter, and she was seeing 20/20, so that's 6.6 1.0. And here's some pictures of the lens. So it was an absolutely fantastic fit. The patient was delighted, and I was delighted. You know, you're saving in chair time, and so you're just looking at follow-ups then at that stage. That's just an OCT, so you can see the amount of scarring and how flat the cornea was because of the lipid keratopathy. This is the lens on eye. So, like, one of the things that I love about this design is the size of the landing zone. Really big, spreads out the weight of the lens really nicely. You don't get lenses settling back so much. No impingement. Our inner landing zone blanching because the distribution of the weight is so nice. So really happy with the fit. This second case was very interesting, and I'll show you why it was such a good result. But basically, he's a 42-year-old male, grade 3 right keratoconus. He had a previous history of right sim-LC. So sim-LC is simultaneous laser and cross-linking. So they will do PRK or topography guided PRK to regularize the cornea as much as possible, and then they'll cross-link to essentially lock that shape in. What you can notice actually if you do that sequentially is, so same day, is that you can end up with a lot of stromal haze, because it's a lot for the cornea to take. Now, a lot of the times, if you're doing sim-LC, you'll do the topography guided laser first, and then you'll cross-link about 6 weeks later. So again, that's his right eye. So a huge differential across the cornea. So there's about a 20 diopter change from superior to inferior. Really irregular. His left eye actually sees very well, even though he has keratoconus in that eye as well. But you can see in the pupil area, it's relatively regular. Again, central thinning of this is an epithelial map. Central thinning of the epithelium, again because of the keratoconus. That's the haze that he has. Again, this is something that you typically see with sequential sim-LC. I included this. This is, I'm not sure if I'm sure you probably heard this before, but a good way of seeing if you're going to make a decision between a corneal lens and a rigid, and a scleral lens, if the height difference across the cornea is over 300 microns, the chance of success with an RGP is very low. You'll probably guess that from looking at scans anyway, but you know, if you do have access to height data, it's good to look at. So again, here's our ESP scan. Very happy with that. What I want to bring your attention to is just in the bottom right, is this the HVID versus the VVID. So it's a pretty big difference in the HVID and VVID, and that's important. So if you do have an oval shaped limbus, like you would in this case here, you would expect the lens to land, if you were going for a preformed out of the box lens, you'll expect the lens to land in the horizontal meridian much closer to the limbus compared to the vertical meridian. So you'll get lots of clearance vertically, very little clearance horizontally. And that can be an issue for the fit. This patient, just to throw a spanner in the works as well, had a large pinguecula. So oval shaped limbus, large pinguecula. If there is ever a case for a freeform lens, this is it. So again, looking through the data, tangent angles is very good. There's the pinguecula, it was massive. Like those things will keep you awake at night. So sent things on to Bernd, who designed the lens. That's the lens over the pinguecula, zero compression. Excellent fit. But what I want to show you here is that look at the bleed of the fluorescein just past the limbus. Okay, so you can see that nasally, very, very nice and even. Then if you look all the way around the lens, it's a perfectly even bleed of fluorescein. So Bernd has incorporated the oval shaped limbus to get perfect distribution of the lens and perfect fit. Again, if this was a preformed lens, you'd expect it to be very, very, very little clearance horizontally, and for there to be a lot of clearance superior and inferior. And that's an issue, because if you have a lot of limbal clearance in one particular direction, you'll end up getting a lot of conj prolapse. So again, yeah, you can just see how even that bleed of fluorescein is. It's just really great, really well aligned, and the patient was very, very happy. So again, nicely designed lens. There's the landing zone, so nice even distribution. That's actually that is over the pinguecula. And again, that's the going through the patient and showing them the design, and that's the lens itself. So again, holding it up, you can see how like it's like a fingerprint, it's highly customized, and that's why you get such a good fit. And I think next one is, that's Bernd. It's for you.
So I bring another case. It's also a keratoconic, or no, it's a pellucid marginal degeneration case on the right eye, and keratoconus on the left eye. I will show you the left eye, because both eyes came up with pinguicula, and the pinguicula was more advanced on the left eye than on the right eye. And this patient was also referred to me. She tried lenses before with notches, and but the lens wasn't stable on the eye, so also irritations and midday fogging, and so that's why she was referred to me to try to improve the fit with a freeform lens. And we take a scan of the patient, but I will show it to you on the ESP side, and so we can see here. I hope everybody can see the screen. Okay, very good. So you can see the pinguicula here. I just go over and export the CSV data file and import that into our software. Case 2, right. Okay, so power was minus 1.75 and a bit of cylinder, but it's not so necessary to show that. And now we see here the profile. I turn the profile to the nasal region. You can clearly see here that bump in the data. So this is the pinguicula. And when I switch on all the sections and all the radius, you can see how smooth the lens will go over that pinguicula. Because of the pinguicula, I decided to make the lens bigger. So also the 16.7 total diameter was the biggest diameter for that scan. And now let's show that lens with all the data. So that is the lens on eye. You can see here this section, when I move it, how it smoothly goes over the pinguicula. I decide, because by the pinguicula, the lens, for me, it's a bit too thin here. So I decide to pump up slightly the center thickness of the lens, so to have a bit more material here. And also I decide to make the edge thickness a little bit higher to avoid that nose that you was seeing before. And when I check the data, check the landing zone, every time I can switch back to see better the transitions, something like that. So I increase a bit the limbal clearance zone diameter in that case. That makes the lens here a bit smoother in the transition. And without the eye data, I can better see how the lens goes over from the cornea into the conjunctiva. So let's go back to see the result. So this is the lens on eye, just taking with white light. Here we have no compression of the pinguicula in that region. For me, the lens is well centered and shows also a good clearance, and not only in the center. So for me, it's okay after several hours of viewing. But what I want to highlight with this picture is how smooth the lens in the scleral landing area is going over the pinguicula. You can see here the pinguicula, and there's no impingement or something like that. And yeah, that's really nice. And also for me, an advantage of freeform lenses is that we can calculate the lens really slim in the design. So the lenses are highly comfortable. And also in this case, some more OCT pictures, nice clearance over the entire cornea. It runs smoothly over from the cornea into the conjunctiva and the scleral landing zone. And once again, here's a vertical picture showing the clearance. So no midday fogging. The saline solution is crystal clear under the lens. So very nice. Here, once again, fluorescein picture and some other slit lamp sectional pictures. And also in that case, with the first lens, we achieve a really great comfort for that patient just with the first lens. She isn't reporting midday fogging anymore. It seems to be simple with one lens to quit that case. But the lens before with notches and something like that is highly, yeah, how to say, you need a lot of experience. I think you need a lot of lenses to make notches and to have it in the right position and something like that. And yeah, so she was highly satisfied. And when the patient is satisfied, also I am satisfied. And I'm lucky that I can, or happy that I can fix problems in shorter times by using the technology, the ESP, and also, of course, our lens. And it's a big step forward into the future. And I think this will be the future, of course. So I think, yeah, that's it.
Wonderful. Thank you, Cian. Thank you, Bernd. There were a couple of questions whilst you were presenting, and I would like for you, Bernd, there is a question from Javi Rojas, who asked, how do you determine the lens diameter? What is your, how do you go about that?
So mainly it depends on the scan. Let's say we have a scan, we can make 18, 19 millimeter of total diameter. So there's no limitation in the scan for the diameter. I usually choose the horizontal wide to wide plus 4 millimeters. But I always ask the customer, what is your own thinking about the total diameter? How big should it be? And I try, especially with new customers, to find out how they like the lenses and the total diameter, because I know from the past, some customers want bigger lenses, some customers want smaller lenses. When we look to the trend in the few last years, I think that the total diameter is a bit decreasing in size. Maybe it is easier to fit, but when we first introduced our normal or general eye matrix lens to the market, we was used to make really big diameters, and with time the diameter was decreasing. But with that technology, I more and more go over also for my patients to fit the lenses more bigger. But it depends, of course, on the scan.
Yeah, I would. I remember having this conversation with Bernd as well. As like I would tend to go, if I can, if the data allows, go for a larger lens. But again, it's very dependent on HVID. So the if they have a large cornea, you know, you're usually better off fitting a larger lens, just so you make sure that you clear it. But that being said, with the Freeform, and that's something that I'm going to check in time, is a lot of these very irregular eyes, and you're going for smaller lenses. You might have issues with settling back and like maybe impingement and things like that. But with a free form, because you're really fitting the eye as well as possible and following the contours, my guess is that could be less of an issue. So fitting a smaller diameter could still work out quite well.
Yeah.
Yeah. Okay. Very good. Thank you. There was another question from David Burkow about over-refraction and when to where in the process to determine that.
Yeah, that's a good question. So I want to talk about it during the slides, but I forgot. So when you have that technology, the ESP, and a patient is calling you for an appointment, make sure that the patient comes without lenses on eye for at least 48 to 24 hours. Depends on the fit before, but sometimes you do not know the fit of a regular scleral lens before. So make sure that the patient is not coming with lenses on eye and take it off in your office and you take the scan, because when you have impressions, you also measure the impressions from the previous scleral lens and you transfer it directly into the lens. So it's not the idea. So make sure you have enough time in between. And first thing I do is to take a scan, analyze the scan. When I think the scan is good, I load it up into our software and check it also on this side. And when I see that's good, I can use that scan. It will create a good lens. I go over and place a lens out of my trial lens on that patient eye and take an over refraction, of course. When I have to see the trial lens on eye, so I see the clearance, or I observe the clearance, and I want to have the clearance in the right area, I would say. So sometimes it's better to have less clearance instead of too much clearance for the over refraction. And I just take the over refraction, and these are my informations that I, when after give also into my software. I know the base curve, I know the power of the trial lens, I have my over refraction. When I place a sclerotoric design on that eye because of sclerotoricity, I don't care about the stabilization marks in which position they are showing to me, because we calculate the freeform lens is always on 180 degrees stabilization. And when the adaptation is quit for that moment, and I order the lens and let the patient come back to see what it is.
Yeah, so I think you'll see pretty quickly if the patient has worn their scleral lens the minute you take a scan, especially on the grid, on the grid section, you'll see it show up more or less straight away if they've been bold and not listened to you.
Typically, you can see it on the ESP in scans. That's true.
Yeah.
We have another question. Sorry, go ahead.
Just if they're very dependent on their lenses, I'll usually say if they leave their lens out on a Friday evening after it out for the weekend, and then they come and get scanned on a Monday. It it works out well for the patient. And again, they might do one eye at a time, and that's a way to work around it if they're very dependent on lenses.
Yeah.
Awesome. Thank you. We have another question from Alex Brochare about when the eye is dry, how do you handle that? And I can perhaps I mean, but eaglet eye, of course, a lot of scleral lenses are fitted on pathologic eyes, and therefore the tear film will be disturbed, sometimes to a great extent, sometimes to a small extent. So in the end, our technology measures the tear film. So it is very important that the tear film is in optimal condition. And so what I can reflect back from what we hear from our users across the world is that there's a couple of things here. So hyaluronic acid is a fantastic way to stabilize the tear film. And we have people where they know they will get that the patient has a severe dry eye. They will give a mini bottle of hyaluronic acid containing eye drops to the patient and say that 3 days ahead of the appointment, they ask them to, several times a day, to self-lubricate their eyes so that when they come to that appointment, their tear film will be absolutely optimized for what is possible for that eye. And they say that almost all of the time they will be able to get a good scan. Any other experience that you have, Cian, perhaps?
Yeah, like when someone comes in for a scleral lens assessment or a contact lens assessment in general, we'll always check the tear film. If they are very dry, like you said, we'll send them off with a dry eye regime to try and optimize the tear film before we take scans. But look, it's also important that they're doing that type of work if they want to continue successful lens wear. So it's, you know, it's going to benefit the patient long term, but it'll benefit in the short term in terms of getting a good scan.
Awesome. Okay, so we saw a number of very good cases and wonderful questions. Thank you so much for everyone participating. I think we had a wonderful session here. We thank you all. Stay in touch, follow us on social media, and contact us. We can do a very good online demonstration showing you through the paces. There's the information for Appenzeller as well. Let us know how we can help you improve your specialty lens fitting and any other questions that you might have. Thank you, and we'll hope to see you very soon in one of our future webinars.
So thank you also from my side. Cian, thank you very much. Hope we see us soon. And Arnie, see you on the weekend.
Looking forward to seeing you at the Opti.
Thank you so much.
Thanks for coming up with such a good lens design, Bernd. It's great. So far, it's been amazing.
Thank you so much, Cian. Thank you so much.
Awesome.
Bye-bye.
Thank you.
Good night.